Okay, let's unpack this. Imagine your kidneys, right?
Mm.
These organs quietly doing their job, filtering blood. But what happens if the arteries feeding them blood start to, well, narrow?
It's a major issue. It can cause this sort of ripple effect through the body.
Yeah, leading to some really tough health problems, especially this stubborn kind of high blood pressure.
That's right. The kidneys are just so central to regulating blood pressure, compromise their supply, and that whole balance gets thrown way off.
And that specific problem is exactly what we're getting into today. This deep dive is all about renovascular disease, RVD for short.
Hmm.
Our guide here is a really detailed medical chapter. It lays out the whole landscape, what RVD actually is, how it links up with hypertension, who's likely to get it, how doctors figure it out.
And the treatments. Critically, what the options are, including, the latest thinking and maybe some of the controversies around it.
So think of this as your way to get up to speed on a pretty complex topic without having to wade through all the dense medical text yourself.
Exactly. We'll break down the problems, the signs to look for, how clinicians actually see inside these arteries, and the different ways forward.
Right, let's start right at the beginning. What exactly is renovascular disease?
Okay. So, at its core, RVD refers to diseases that mess with the arteries supplying blood to your kidneys. We often think of atherosclerosis plaque buildup, and that's a big one.
But not the only one.
No, definitely not. It also includes things like fibromuscular dysplasia, which is different, and even some inflammatory diseases that can hit those specific arteries.
And when those renal arteries narrow, that's when you can get this specific type of high blood pressure, renovascular hypertension, RVH.
Precisely. RVH happens when that reduced blood flow, we call it renal ischemia, is a direct result of that narrowing. Now, look, high blood pressure itself is incredibly common. Affects, maybe 78 million adults in the U.S.?
Yeah, huge numbers.
Right. But RVH is a less common cause of that high blood pressure. Maybe around 5% of cases. Still, that's potentially upwards of 4 million people, so it's significant.
And the source says the most common reason for RVH is renal artery stenosis, RAS. That's the actual narrowing itself.
Yes, RAS is the physical problem, the narrowing. And what's interesting, or maybe concerning, is that you often see it in people who already have plaque buildup elsewhere, like in their carotid arteries going to the brain, or peripheral arteries in the legs.
Oh, so it's often part of a bigger picture of vascular disease.
Often, yes. And it's linked to a higher risk of serious heart problems, too.
Okay, so if RAS is the main pathway to RVH, what's causing the RAS itself? The source mentioned two main players.
Overwhelmingly, yes. Two main culprits. Atherosclerosis is the big one, accounts for something like 90% of cases.
90%, wow.
Yeah. And the other 10% or so is fibromuscular dysplasia, FMD.
Okay, let's dig into those. They sound quite different. Atherosclerotic RAS, or RAS first, the common one. What's happening there?
It's basically the familiar process of plaque. The inner lining of the artery gets thicker, you get lipids depositing underneath it, and it just progressively narrows the opening. Sometimes it can even block it off completely.
And where does this usually happen in the renal artery? Is it a specific spot?
Typically, yeah, it's often right at the beginning where the renal artery comes off the aorta. That's called the osteum, or maybe in the first third of the artery, the proximal part.
And who tends to get ARS?
Primarily people over 50. Men seem to be at higher risk than women. And it's really strongly linked with smoking, hypertension that's hard to control, and, like we said, having atherosclerosis elsewhere.
It tends to get worse over time.
It does. It's progressive. Often leads to pretty significant narrowing, maybe 50–70% stenosis or more.
The source mentions some serious complications linked to ARS.
Oh, absolutely. It's a major driver of kidney function decline, sometimes leading to outright kidney failure. Especially if both arteries are affected or if someone already has kidney issues to begin with.
And beyond the kidneys?
It significantly bumps up the risk for mortality and other health problems, usually driven by the related heart disease. You might also see changes on an echocardiogram, like the heart muscle thickening up or having trouble relaxing properly.
Okay, so RAS plaque, older folks, often other vascular problems. Now, the other path, fibromuscular dysplasia, FMD. How's this different?
Fundamentally different. It's not inflammatory. It's not atherosclerosis.
Yeah.
FMD is, it's more like an abnormal development of the artery wall itself, a defect.
A defect in the wall structure.
Exactly. The most common type affects the middle layer, the muscular part that's called medial fibroplasia, about 85% of cases. It rarely involves the inner or outer layers like plaque does.
And location-wise, it's usually different too.
Yeah, FMD tends to pop up more in the middle and distal parts of the renal arteries, further down the pipeline, so to speak.
And the typical patient is very different from area.
Totally different profile. FMD is much more common in children, young adults, and women, particularly during their childbearing years. There's sometimes a family link too, maybe 10% of cases.
Is there a classic look on imaging studies?
Yes, the angiogram often shows this pattern described as a string of pearls or string of beads.
String of pearls. Why is that?
It's because you see these alternating areas of narrowing, the stenosis, and little bulges or aneurysms along the artery. Looks like beads on a string.
That's a great visual. And unlike ARAS, FMD isn't just limited to the kidney arteries.
Correct. That's another key distinction. FMD can show up in lots of other arteries: carotids, vertebrals in the neck, iliac arteries in the pelvis, mesenteric arteries supplying the gut.
So what kind of problems does FMD cause in the renal arteries specifically?
It can lead to aneurysms, those little microaneurysms, stenosis, obviously dissections, which are tears in the artery wall, and even thrombosis, blood clots.
But maybe less likely to cause complete blockage than ARA.
Generally, yes. Compared to ARNS, it's less likely to lead to total occlusion or really severe ischemic kidney damage.
Okay, so two very distinct paths. ARS from plaque, typically older patients with other risk factors, and FMD, a structural issue, often younger patients, especially women, potentially affecting multiple arteries. But both can mess up kidney blood flow and trigger RVH. How exactly does that reduced flow crank up blood pressure?
It all comes down to this key system, the renin-angiotensin-aldosterone system, or RAAS.
Okay.
When the kidney senses that reduced pressure or flow because of the stenosis.
It basically thinks the whole body's blood pressure is too low.
Exactly. It gets fooled. And its response is to kick off this powerful hormone cascade designed to, well, raise blood pressure and hang on to fluid.
Walk us through that cascade. What happens first?
Okay. The kidney releases an enzyme called renin. Renin floats around and finds a protein made by the liver called angiotensinogen. It converts that into angiotensin I.
Angiotensin I. Okay, then what?
Angiotensin I travels, mainly through the lungs, where another enzyme, ACE, angiotensin-converting enzyme, changes it into angiotensin II.
And angiotensin II, that's the big one, isn't it?
That's the powerhouse. Angiotensin II does a couple of major things. First, it's a really potent vasoconstrictor.
Meaning it squeezes blood vessels.
Exactly. It tightens up arteries all over the body. This increases peripheral resistance, making it harder for blood to flow, which directly jacks up systemic blood pressure.
And that's not all it does.
Nope. It also tells the kidneys directly to reabsorb more sodium and water back into the blood. And on top of that, it stimulates the adrenal glands, which sit right on top of the kidneys, to release another hormone called aldosterone. And
aldosterone adds fuel to the fire.
It does. Aldosterone makes the kidneys retain even more sodium and water, so you get this double whammy: vasoconstriction plus significant fluid retention.
So tighter pipes and more fluid volume trying to push through them.
Yeah.
I can see how that leads to high blood pressure. Does it matter if it's one kidney artery affected or both? Does that change the hypertension?
It definitely can. With unilateral RAS, just one side narrowed, that kidney really cranks out renin, making the hypertension very renin-dependent. The other, healthy kidney, might even try to compensate by reducing its own renin.
Okay. But if both are narrowed, or someone only has one kidney,
then it can get more complicated. Over time, the sheer volume overload from all that fluid retention can become the dominant factor. Renin production might actually decrease. This leads to hypertension that's more fluid-dependent, and it can put a real strain on the heart, potentially leading to heart failure. And the source notes, bilateral RAS carries a higher mortality risk.
And either way, unilateral or bilateral, the kidneys themselves can suffer damage over time.
Absolutely. Both types of RAS can eventually lead to renal impairment, ischemic nephropathy, basically, a drop in the kidney's filtering ability, the GFR.
Okay, before we jump into diagnosis, maybe just a quick refresher on kidney location. Where are they exactly?
Sure. They're tucked away in the back, behind the main abdominal cavity, what we call the retroperitoneal space. One on each side of the aorta and vena cava, those big central vessels.
And size-wise?
In adults, usually around 9 to 11 centimeters long, maybe 5 to 7 wide, couple centimeters thick. Weight varies, maybe 115 to 170 grams. The right one often sits a bit lower because the liver's above it. And size can vary a bit with sex and age.
And blood comes straight from the aorta.
Yep, the main renal arteries branch right off the abdominal aorta. And it's actually pretty common for people to have more than one artery supplying a single kidney accessory artery. So that's important to know for diagnosis and treatment.
And inside the kidney, those arteries just keep branching.
They do, smaller and smaller, eventually becoming the tiny afferent arterioles that feed the glomeruli, the little filtering units, the nephrons. So a blockage anywhere along that path can cause trouble.
Right. So given that RVH is a cause of hypertension, not just hypertension itself, figuring out who might actually have it seems critical. What are the clues?
Several things should raise suspicion. Race plays a role. It seems more prevalent in Caucasians. Age is a huge factor, as we discussed. Think FMD in the 15 to 30 range, ARS much more likely over 55.
And if someone already has known artery disease elsewhere, like heart disease.
Definitely a big red flag for ARS. Existing arteriosclerosis is a major clue. Same with smoking history, current or past.
What about the hypertension itself? Are there specific patterns that scream RVH?
Yes, absolutely. High blood pressure starting really young, before age 30. Or the opposite sudden onset of severe hypertension after 55.
Okay.
Also, accelerated hypertension when blood pressure that was controlled suddenly gets much worse and stays bad. Resistant hypertension is another big one. BP still high even on 3 different meds at full doses, including a diuretic. And then malignant hypertension, where the high BP is actually causing organ damage.
So those patterns, especially combined with the right demographics or risk factors, should make you think RVH. What does someone with RVD actually feel? Any symptoms?
Often surprisingly little directly from the RVD, especially with FMD. The high blood pressure might be the only sign. Yeah. With ARS-related RVH, maybe more symptoms like fatigue, changes in vision, headaches. If they have related heart or leg artery disease, they might feel pain from that, sometimes swelling in the legs, or just finding it impossible to get BP controlled with pills. Very rarely, they might get sudden fluid in the lungs, flash pulmonary edema, causing severe breathlessness.
And on a physical exam, what might a doctor find?
Well, consistently high blood pressure, obviously. The diastolic might be really high, like over 110 in younger FMD patients. Systolic over 160 is common with ARS, sometimes higher readings at night. The classic sign, though not always there, is an abdominal brute.
A brute. That's like a wishing sound.
Exactly. Heard with a stethoscope over the abdomen near the midline or flank. It's from turbulent blood flow through the narrowed artery.
Is finding a brute definitive?
It's a strong clue, but you can definitely have RVD without one. Other signs might include changes in the blood vessels in the back of the eye, flank pain if the kidney's really ischemic, maybe weak pulses in the legs if they have PA, and signs of fluid overload, leg swelling, crackles in the lungs.
It really seems like you need to think about RVD differently depending on the patient's age.
You absolutely do. In kids or young adults, say under 25, you'd suspect RVH with sudden severe hypertension, maybe flank pain without infection, or BP that just won't respond to normal meds. Severe hypertension popping up suddenly in a young person with no family history, that's a big flag.
And for women of childbearing age.
Higher risk for FMD. So, again, abrupt onset or resistant hypertension are key clues, maybe alongside symptoms related to FMD and other arteries they might have.
Then for the older group, over 50, where ARA is more likely.
Yeah, here it's often about monitoring folks who already have risk factors, known heart disease, PAD, chronic kidney disease. Check their BP and kidney function regularly. Specific clues in this group. An abdominal brute, malignant or accelerated hypertension. New high blood pressure after 50 or 55, sudden worsening of BP control, kidney function getting worse after starting an ACE inhibitor or ARB. Seeing generalized atherosclerosis elsewhere, a big size difference between the two kidneys on imaging, like more than 1.5 centimeters, or that unexplained flash pulmonary edema.
Wow, lots of potential clues. So once you have that suspicion based on history, risks, BP patterns, exam, how do you actually confirm it? How do you look inside?
The usual approach is to start with non-invasive tests. If those point strongly towards RVD, or if they're unclear but your suspicion is super high, then you might move to invasive angiography, which is kind of the gold standard for visualization.
Is there a clear cutoff for how much narrowing counts as significant?
That's actually a tricky part, and the source highlights this. There isn't one single universally agreed upon percentage. Sometimes it's 50%, sometimes 70%, or 75% stenosis. Other times it's defined functionally. Did fixing it actually help the blood pressure? So it's not always black and white.
Okay, let's talk imaging, the anatomical test. What's usually the first step?
Often it's a renal duplex ultrasound. It uses sound waves like sonar to make pictures of the arteries and kidneys, and Doppler measures how fast the blood is flowing.
And certain flow patterns suggest a blockage.
Exactly. Things like really high peak velocity in the renal artery, a high ratio comparing that velocity to the aorta's velocity, or a delayed upstroke in the Doppler signal. A big size difference between kidneys can also be a clue.
Pros and cons of ultrasound.
The big pro is it's non-invasive, no radiation, no contrast dye that can harm kidneys. But it's very operator dependent. The quality really depends on the technician's skill. It can be tough in patients with obesity or lots of bowel gas blocking the view, and it might miss blockages in smaller branch arteries or accessory arteries. Accuracy reports vary quite a bit.
Okay. What about CT angiography, CTA?
CTA uses X-rays and an iodine-based contrast dye injected intravenously. It gives really detailed cross-sectional and 3D images, excellent for seeing the main renal arteries, including those tricky nostril lesions right at the beginning and any extra arteries. It generally matches up well with traditional angiography. The main one is the iodinated contrast. Risk of allergic reaction, and it can be nephrotoxic, potentially harmful to kidneys, especially if function is already poor. It's also more expensive and can't be done if someone's severely claustrophobic.
Then there's MRA, magnetic resonance angiography.
Right. MRA uses powerful magnets and radio waves, usually with a gadolinium-based contrast agent. Gadolinium is generally thought to be less tough on the kidneys than iodine contrast.
But not zero risk.
Not zero, especially in advanced kidney disease. There's a rare but serious risk of something called NSF. MRA is pretty good for visualizing the main arteries and blood flow.
Limitations of MRA.
Takes longer, also expensive, can't be used with certain metal implants, pacemakers, or, again, severe claustrophobia. Might not be as good for seeing tiny branch arteries and can sometimes make moderate blockages look worse than they are.
So these non-invasive tests give you a picture. But if things are still unclear or you're pretty sure you need to intervene, then it's the invasive angiography.
That's usually the next step, yes. Intra-arterial digital subtraction angiography, DSA. Still considered the gold standard, a catheter is threaded up through an artery, usually in the groin, right into the renal artery, and contrast is injected directly while X-ray pictures are taken.
And that gives the clearest view.
The most detailed anatomical map, yes. Location, severity of narrowing artery contours. You can also do extra things during the procedure, like measure the pressure drop across the blockage, or use intravascular ultrasound IVUS, a tiny ultrasound probe on the catheter to see inside the artery wall itself.
And the huge advantage is if you find something treatable.
You can often fix it right then and there. Angioplasty, maybe placing a stent, can frequently be done in the same session. Saves the patient another procedure.
What are the risks with DSA, though? It sounds more involved.
It is. There are risks from the contrast dye, like allergy or kidney injury, especially in vulnerable folks, but there are also risks from the catheter itself. A big one is atheroembolization, knocking loose bits of plaque that can travel downstream.
And cause more problems.
Yes, potentially worsening kidney function, sometimes severely, or causing blockages in the feet, the blue toe syndrome, plus risks at the puncture site, bleeding, bruising, artery damage.
Okay, so that's looking at the anatomy. The source also mentioned functional tests, trying to see if the blockage is actually causing the high BP.
Right. These are usually considered when you have confirmed RVD, especially on one side, and you want to know if fixing that lesion is likely to actually improve the hypertension. It's a key question, but honestly, no single test is perfect at predicting that.
What are the options there? Renal venous renin sampling.
Yes. That involves taking blood samples directly from the veins, draining each kidney, and measuring renin levels. The idea is the affected kidney should be churning out much more renin than the healthy one. A ratio above a certain threshold, like 1.5 to 1, is considered positive.
Does it work well?
It can help guide decisions, but the source notes it has problems with both false positives and false negatives. It's very sensitive to how the samples are collected, patient hydration, medications.
Okay. What about captopril
This is a nuclear medicine scam. You get a baseline scan showing kidney perfusion and function, then you're given an ACE inhibitor like captopril and scanned again.
And what are you looking for?
If a kidney has a significant blockage, giving captopril, which blocks angiotensin II's effects, can sometimes paradoxically worsen its function or tracer uptake excretion on the scan. That suggests the kidney was relying on that angiotensin II effect to maintain filtering pressure, implying the stenosis is physiologically significant.
Is that reliable?
It can be helpful, maybe for identifying patients likely to benefit from fixing the artery or for evaluating borderline lesions, but it's less reliable if kidney function is already quite poor or if there's bilateral disease because ACE inhibitors affect both kidneys then. Usually not valid if creatinine is already over 2.0.
So you piece together the clinical picture, the imaging, maybe functional tests, and basic lab work is still fundamental.
Absolutely. Basic blood and urine tests are crucial. BUN and serum creatinine give you an estimate of kidney function, the GFR. Creatinine tends to be elevated more often in ARS than FMD. A doubling of creatinine suggests roughly a 50% loss of GFR.
Labs often report eGFR now, right?
Yes. Estimated GFR, which accounts for age, sex, etc. But remember, creatinine can be affected by muscle mass, diet, some meds.
What about creatinine clearance?
That's a more direct measure using blood and a 24-hour urine collection. Can be more accurate, but tricky because if one kidney is compensating well, the overall clearance might look normal even if the other kidney is struggling.
And urine tests, specific gravity,
Yeah.
protein.
Specific gravity tells you how well the kidneys concentrate urine can be low in hypertension. Urine protein is really important for assessing kidney damage, especially glomerular damage. It can be elevated from various kidney diseases, but also from vascular disease like hypertension itself.
And for ARS specifically, checking lipids is key.
Essential. Cholesterol panel total, HDL, LDL, triglycerides. High LDL is a major driver of the atherosclerosis causing ARS. Doesn't diagnose RAS itself, but it's vital for managing the underlying risk.
Okay, quite a diagnostic journey. Once RVH is confirmed, what's the management strategy?
It's usually a combination approach. Aggressive medical management is always the foundation. Then, depending on the situation, you might consider catheter-based procedures or even surgery.
Let's start with medical management. What's the focus?
Especially with ARAS, the main goal is hitting all those atherosclerotic risk factors hard. Stop smoking, absolutely critical, exercise, low-salt diet, get blood pressure under tight control, manage lipids.
Medications for blood pressure.
ACE inhibitors or ARBs are often first choice, especially for unilateral disease because they directly target that RAS system. But you have to be cautious.
What's cautious?
Because in bilateral stenosis, or if someone only has one kidney, these drugs can sometimes cause a significant rise in creatinine, worsening kidney function. So you must check BUN and creatinine within a week or so of starting them.
Okay, so close monitoring is key there. What else for BP?
Beta blockers, calcium channel blockers, diuretics are also common. With diuretics, again, you need to watch kidney function.
And for cholesterol?
Statins are standard. They lower LDL, reduce cardiovascular risk, and there's even some thought they might slow down the progression of the stenosis itself. Niacin might be used to boost HDL.
Antiplatelets, like aspirin.
Generally recommended, yes, particularly if there's known heart or peripheral artery disease alongside the RAS.
So intensive medical therapy is step one. But the source mentioned intervention fixing the artery is kind of controversial.
It is, and this is really important. While opening up the artery seems intuitive, the big clinical trials have raised serious questions about whether it consistently adds benefit over really good medical therapy for many patients, especially with ARS.
So the guidelines are pretty specific about who definitely needs intervention.
Yes. The strongest recommendations, like the ACC FAHA Class I for ARIS, are fairly narrow, mainly for patients with recurrent, sudden heart failure episodes or that flash pulmonary edema we mentioned. Some doctors use grading scales, like the Roche-Ising scale, to try and pinpoint patients who might benefit more, like those with kidney dysfunction plus really hard-to-control hypertension or fluid overload.
Is the trend generally towards less invasive options when intervention is chosen?
Generally, yes. Catheter-based approaches are often preferred first because they're less invasive than open surgery. Though for certain situations like those ostial error ACE lesions with kidney impairment, open surgery might still yield better long-term results.
Let's talk about the catheter options: angioplasty, PTRA, and stenting.
Okay. PTRA is percutaneous transluminal renal angioplasty, basically using a balloon to stretch the narrowed artery open. For FMD lesions, the recommendation is usually PTRA without putting in a stent.
No stent for FMD.
Generally not needed. Angioplasty alone works well. But for atherosclerotic lesions, especially those ostial ones, PTRA with an expandable stent is usually the way to go. The stent acts like scaffolding to hold the artery open.
And how well do these work?
For FMD, PTRA has really good long-term patency, keeps the artery open. Studies show it can cure hypertension in a good chunk of patients, maybe around 46% overall, even higher in kids.
And for ARIS?
Angioplasty alone for ARIS often leads to re-narrowing, maybe almost 50% of the time. Adding a stent dramatically reduces that restenosis rate down to maybe 16% at a year. Procedural success is very high, over 95%, and it might help stabilize or improve kidney function in some patients.
That's where the controversy comes in, right? Does that technical success always mean better outcomes than meds alone?
Exactly. That's the million-dollar question the trials tried to answer. Just because you can open the artery doesn't automatically mean the patient does better long-term compared to just optimizing their medications rigorously.
What are the main risks of angioplasty and stenting?
Bleeding at the access site, restenosis, the artery narrowing again, often inside the stent, and that atheroembolization risk plaque breaking off, which can have serious consequences for the kidneys or limbs.
Okay, what about open surgical revascularization?
Surgery is still an option for both FMD and ARS. As mentioned, it's sometimes considered superior for complex ARS, especially osteolesions with kidney dysfunction. Surgical bypass grafts tend to have excellent long-term patency, over 90%.
Better than angioplasty long-term for some.
For non-atherosclerotic disease like FMD or Takayasu arteritis, surgery generally has better long-term patency than PTRA alone. And BP improvement rates are very high, around 90% in those cases treated surgically.
What kind of surgery?
Most common is an aortorenal bypass, creating a new path for blood flow. Other options exist like endarterectomy, cleaning out the plaque, or even complex reconstructions.
But surgery means higher risks.
Oh yes, significantly higher. Mortality is around 5%, maybe 30% risk of major complications, heart attack, stroke, pneumonia, worsening kidney function. It's a bigger undertaking.
And just quickly, removing the kidney. Nephrectomy.
Very rare nowadays. Really only considered if the kidney is completely non-functional, like less than 10% function, or maybe shrunken down significantly after an infarction.
Okay, let's circle back to those clinical trials you mentioned that stirred things up. What did they find?
Right. This is crucial context. The STAR trial specifically looked at patients with ARAS who already had impaired kidney function. They compared stenting plus medical therapy to medical therapy alone.
Huh.
They found no benefit from stenting in terms of preventing further loss of kidney function. And importantly, there are actually 3 reported deaths in the stenting group, 2 related to the procedure.
Wow. No kidney benefit plus procedural risk. That's sobering.
Yeah.
What about the Astral trial? It was larger, right?
Yes, Astral was bigger. Over 800 patients with atherosclerotic RVD compared revascularization, stent or angioplasty, plus meds versus meds alone, followed them for almost 3 years.
And the outcome?
Similar message. No added benefit from revascularization, didn't improve renal function, didn't significantly improve BP control beyond what medical therapy achieved, didn't reduce renal or cardiovascular events, didn't reduce mortality compared to optimal medical therapy alone.
So Astral also strongly suggested just really good medical management was as good as adding an intervention, at least for the patients they studied.
That was the major finding for that population. Now, the source does mention a potential limitation. Astral might have included patients who were less symptomatic, so maybe the results don't apply perfectly to everyone, like those with very severe refractory symptoms. But the overall message was powerful.
The source also mentioned the Corral trial was eagerly awaited.
Yes, CORAL was a big NIH trial looking specifically at stenting versus optimal medical therapy in hypertensive patients with severe ARS. The source chapter was written before the results came out.
And we know the results now.
Yes, and they largely reinforced the findings of STAR and Astral for the primary endpoint of preventing major cardiovascular or renal events. Adding a stent to optimal medical therapy didn't provide a significant advantage over optimal medical therapy alone in most patients studied. There was maybe a modest improvement in blood pressure with stenting, but not a major difference in hard outcomes. An earlier trial, Drastic, from the pre-stent era, did show a short-term BP advantage for angioplasty alone over meds.
So putting STAR, Astral, and Coral together, the big picture seems to be that while we can successfully open these arteries with stents, the evidence from these major trials really challenges the idea that doing so provides substantial clinical benefit beyond intensive medical management for many, maybe most, patients with atherosclerotic RVD, especially regarding kidney function and major events.
That's a fair summary of what these key trials indicated. It really underscores that optimal medical therapy is absolutely critical, the cornerstone of management. And the decision to intervene needs to be very selective, really focusing on those specific patient groups or symptom complexes where the potential benefits might outweigh the risks and uncertainties highlighted by the trials.
Okay, let's bring this home for the listener. If you or someone you care about is dealing with suspected or diagnosed RVH or just really difficult hypertension, what are the key patient care and education points to keep in mind?
The source really stresses the importance of monitoring. That means keeping close tabs on vital signs, BP, pulse, and kidney health indicators, BUN, creatinine, urine output, electrolytes. Watching fluid status is also a key. Daily weights, checking for swelling, catching changes early is crucial.
And if someone does have a procedure,
Then post-procedure care is vital, managing pain, watching the puncture site or incision closely for any signs of bleeding or infection, deep breathing exercises, especially after surgery, to keep the lungs clear.
what are the absolute must-knows for patients themselves?
Fundamentally, understanding their condition, what RVD is, what the treatment options are. Recognizing that lifestyle changes, especially stopping smoking, healthy diet, exercise, aren't just suggestions, they're essential treatment components.
Right.
Keeping up with regular checkups is non-negotiable for monitoring BP, kidney function, overall vascular health, and knowing their medications inside out.
What about the meds?
Really understanding why they're taking each one, the potential side effects, how to take them correctly, potential interactions, including with over-the-counter stuff or supplements, that's critical for safety and effectiveness. Patients also need to know the warning signs, what to look out for that might indicate the RAS is progressing or their kidney function is declining.
And practical things, like after a procedure.
Yeah, knowing activity restrictions, importance of rest, how to care for the wound, what diet helps healing, and critically, knowing exactly when to call the doctor. Fever, wound drainage, worsening pain, changes in how the wound looks. Home BP monitoring is also really encouraged.
Learning how to do that properly, knowing their targets.
Exactly. Knowing their target BP range and what numbers mean they need to call their provider or seek urgent care. It's all about empowering the patient.
And the end goal is always protecting those kidneys long term.
Precisely. Sticking with the whole plan, meds, lifestyle, follow-up is the best way to preserve kidney function. The source also points to great resources like NIH for reliable info.
We've definitely covered a lot today, from defining RVD and how it causes RVH, through the two main causes, RIS and FMD, how the renin-angiotensin system gets involved, the clues for diagnosis, the imaging and functional tests, and then navigating the management options. Medical therapy, angioplasty, stenting, surgery, and importantly, what those big trials like STAR and Astral tell us about when intervention really helps.
It's clear it's a complex area, requires careful diagnosis, and treatment decisions really involve weighing the proven benefits of intensive medical management against the potential, but sometimes uncertain, benefits and risks of intervention, guided by the latest evidence and individual patient factors.
So maybe a final thought for you, our listener, to take away. Given how tricky RVH can be to diagnose definitively, the ongoing debates about the best timing and type of intervention, and this really compelling evidence underscoring just how crucial aggressive medical management is, how might understanding all these layers empower you or someone you know to ask the important questions and really advocate for the most thorough, personalized approach if renovascular hypertension is ever on the table.